could turn back time to the good old days when the mama sang us to sleep, but now we're stressed out.
Hello, and welcome back to part 3 of the endocrine system, and that is our topic. We're going to talk about stress. No one's having any stress out there, right, guys? All right, so we are going to discuss the adrenal gland, and there's two parts to the adrenal gland. There is the outer part of the adrenal gland, which is called the adrenal cortex, and then the middle portion is called the adrenal medulla. Hopefully in AP1 you learned about that short-term stress response, that fight or flight response, that is the release of adrenaline or epinephrine and noradrenaline from that adrenal medulla. And so this is kind of like our alarm reaction. So when somebody cuts you off in traffic, or you realize that, you didn't pay the credit card bill when you told your husband you're going to, those sort of things, those little panic moments that we have. And it's, once again, it's going to be through the autonomic nervous system. And this is going to be neural stimulation. We get neural stimulation and a release of those hormones. And they have a longer lasting effect than when they are released from the end of a neuron. The outer part is called the cortex. And so the adrenal cortex is responsible more for long-term stress, or what's called the stage of resistance. And the cortex has layers to it. And I love this picture because I'm a picture person. And there's 3 different types of hormones that are going to be released from the adrenal cortex. And if you take the word apart, they're giving you a lot of information. So let's look. So there's one layer of the adrenal cortex that is going to release mineral corticoids. And so it's telling you it has something to do with minerals, so our electrolytes. In this case, it's going to be sodium and potassium. Corti, because it comes from the adrenal cortex, and oi, because these are steroid hormones. And so from the adrenal cortex, we are going to get aldosterone. That's going to be the number one we're going to talk about. The adrenal cortex releases about 26 different hormones. We're going to talk about 3. So we're going to kind of narrow it down and put them into groups. The next layer makes glucocorticoids. So gluco from glucose, so sugar. Corti, it's coming from the adrenal cortex, and these are going to be steroid hormones. So this has to do with metabolism. And so we are going to talk about cortisol. Another layer makes gonadocorticoids. So it has something to do with the gonads, so the primary sex organs. In males, testes; in females, it's the ovaries. But in this case, predominantly what is being made by the adrenal cortex are going to be male sex hormones, so androgens, that are being converted to testosterone. In females, it can also be converted to estrogen. So after a woman goes through menopause, the only estrogen that's going to be made is going to be coming from the adrenal cortex. But we're going to look at the histology of the adrenal cortex, and you're going to see the 3 layers, and this is going to be where those 3 different groups of hormones come from. And I guess I forgot to tell you where the adrenal glands are. Whenever you see renal, that always means kidney. So these glands sit on top of the kidneys. So when you look at the histology, you have to think back. This was late 1800s. People were excited. They had microscopes. They were looking at literally everything, and they were giving it names. And so looking at the adrenal glands in cross-section underneath about 40x, so not a whole lot of magnification, they could see that there was an outer layer, so that's why they called it the adrenal cortex, and then they could see there's a difference, a middle layer. When you up the magnification and you look at the adrenal cortex, they were like, oh, look, there's different zones to it. I'm going to be super honest with you, you need a whole lot of imagination, but what they saw, if you look up here, so the adrenal glands, they have a capsule, and then this zone, you kind of see how it's kind of round and circular. You see these little round balls of cells, these clusters of cells. So a Latin term for a little tuft or a little, think like fuzzball of something is a glomerulus. So they called it the zona glomerulosa. When something looks different structurally, it usually has a different function. So this layer is going to be where the mineral corticoids are made, and we are going to just talk about aldosterone. This next zone that they saw with great imagination, I must say, they called it the zona fasciculata. And I don't know if you remember way back to muscles, skeletal muscles have fascicles. So fascicle means bundle. And so they see these long bundles or cords of cells. So they called it the zona fasciculata. For the most part, what comes out of this area, we get cortisol. And so that's going to be a glucocorticoid. We also get some androgens. But predominantly the androgens, the sex hormones, are going to come from the zona reticularis. And that word reticularis means net, so just this zone. And then when you get to the adrenal medulla, and like I said, that's for our short-term stress response. So structure always seeks function.
The stress response. In stressful situations, the body switches on its autonomic nervous system and neurobiological processes in an attempt to maintain homeostasis. The body is prepared for its reaction to stress. In the brain, the hypothalamus is connected to the pituitary gland. The hypothalamus, stimulated by the sympathetic nervous system, releases the hormone corticotrophin-releasing factor, CRF. The CRF activates the pituitary gland to release the adrenocorticotropic hormone, ACTH. This in turn alerts the adrenal glands. The adrenal glands are located on top of each kidney. The ACTH from the pituitary gland stimulates the adrenal cortex to release cortisol. At the same time, neurons in the hypothalamus signal the medulla to release epinephrine, adrenaline, and norepinephrine, noradrenaline. These hormones then push the body into hyperalertness.
Okay, so I've given you this picture. So let's look at the short-term stress response, or what one of the textbooks calls that alarm reaction. We've all felt this, that sort of lurch of adrenaline. You feel it in your stomach, your heart quickens. So like I said, this is going to be that short-term stress response. We're going to get neural stimulus of a release of epinephrine and norepinephrine. So it's about 80% epinephrine, 20% norepinephrine. They do the same things. These are catecholamines, so these are modified amino acid hormones. So we're going to get increased heart rate, increased blood pressure, the bronchioles and the lungs, the airways are going to open real big so we get some oxygen. The liver is going to convert glycogen to glucose and just release glucose into the blood because we're going to take glucose. We need to make ATP because remember, we are in either fight or flight situation. Blood flow is going to change. Blood is going to go to the skeletal muscles, to the heart, to the lungs. We really don't care if lunch doesn't get digested, if we're going to die in the next 10 minutes. Also, rejection of urine output. This is not the time to be filtering blood and making urine. We have a crisis. And so the overall metabolic rate is going to increase. And so we know that this can occur very quickly. Like I said, you've all felt it. And then two, it also will wane in minutes. Prolonged stress or other things too that cause this release from the adrenal cortex. So late stages of sleep, or also it's going to be negative feedback, so low cortisol. So remember, we have our chain of command. We have our hypothalamus, which is the captain. The captain detects, like I said, stress, releases corticotropin releasing hormone to the first mate, anterior pituitary. Anterior pituitary goes, aye, captain, I'm going to get that adrenal cortex going. And then it releases ACTH, adrenocorticotropic hormone. So then the adrenal cortex is going to release, predominantly, we're going to get cortisol. Cortisol is a glucocorticoid. So what's going to happen, this hormone is going to basically release the storehouses of energy. So we're going to get an increase in blood glucose. And the idea behind this is to save glucose for the brain. All the other tissues that can use other energy products, that can use fats, they're going to do that, but we are going to increase blood glucose levels because the idea is if we have glucose, we're going to have energy and we can get out of this stressful situation. We can recover. Think of stress. I know we're all kind of stressed out. I'm a little stressed out in this sheltering at home kind of thing. But think about stress too. It's not just modern day stress, fever, injury, surgery. Those are all stresses as well. But like I said, the idea is to increase nutrients. The other thing about this, though, is you also get a suppression of the immune system. You might be thinking like, well, that doesn't make very good sense. Short term, it's a good thing. The immune system is kind of a hog as far as it's energy it takes. But two, if you are in a stressful situation, and think back, running from a bear, fighting from a bear, hunting, whatever it may be, you really don't want to be concerned like, oh, I got a splinter. So you also get a reduction in inflammation. And so inflammation, pain, redness, heat, swelling, it's going to slow those white blood cells going to those areas. In short term, it's an okay thing. Long term, it's not. And so long term stress as it continues on, so think like weeks or months, then you get the stages of exhaustion. And so we are breaking down proteins and fats and kind of converting all of those to glucose. So that's when you get, wasting, muscle wasting, breakdown. You have a 20% higher chance of illnesses. It also decreases wound healing by about 40%. So super long-term stress, you get to that stage of exhaustion. So you don't really want that. But in normal amounts, cortisol is a good thing. It helps us recover from stress. Pop over here, because also from the adrenal cortex, we're going to get mineral corticoids, so aldosterone. Aldosterone target is going to be the kidneys. It's going to tell the kidneys, hey, reabsorb sodium. Whenever we reabsorb salt, water follows. That's going to increase our blood volume and our blood pressure. And the idea behind that is if we have greater pressure, we're going to get greater delivery of those nutrients to the body so we can make a lot of energy, increase our rate, and then recover from the stress. So we've got short-term stress response, adrenal medulla, through neural stimulus, we get that release of catecholamines. Then we have our long-term prolonged stress response from the adrenal cortex that helps us recover. We get predominantly cortisol. Also coming from that adrenal cortex, we get aldosterone. There it kind of is for you as well. So where the energy is coming from, the immune system, like I said, it's going to be suppressed. The liver is going to make glucose from non-carbohydrate sources. Muscle is going to go through protein catabolism. We're also adipose tissue, lipolysis. We are going to break down fats. Once again, all that's just to increase the amount of glucose in the blood, and we're going to get glucose sparing for the brain. Brain likes glucose. We're going to inhibit tissue building because, once again, you don't fund a building project if you are in a crisis. And then two, it suppresses the immune function. So if you've ever rubbed the hydrocortisone cream on an insect bite or something, you use this hormone. Since it was a steroid, it could be delivered transdermally. So cortisone shots in the joints, prednisone would be another one. These are all variations of cortisol. And so they reduce inflammation. They're used clinically to treat autoimmune disorders. They can have negative effects, especially if someone has to take them long term. Once again, you get an increased risk of infections, increased chance of cancer, also causes an increase in sodium and water retention. But this is used clinically all the time because of its ability to suppress the immune system. Also, it's cortisol and a lot of other hormones released in a diurnal fashion. So it's just showing you more early in the day and less later in the day. I'm not really going to ask you that. So let's look at aldosterone. Cortisol is sort of the stress hormone. Aldosterone, this is your first time hearing this. You are going to hear about aldosterone unit 1, unit 2, unit 3. Aldosterone is not going away. So there's other things that are going to trigger the release of aldosterone. And so just kind of showing you stress, you get ACTH. And remember, aldosterone is the one, it's a mineral corticoid. So we are going to reabsorb our sodium, water follows. And when we reabsorb sodium, in this case, we are going to kick out and get rid of potassium. I'm just introducing that part to you. It is a mineral corticoid. It is going to increase absorption of sodium in water. We're going to increase blood pressure and increase blood volume. The big thing that's going to trigger this, that's going to come up later, I'm just going to throw this out to you now, but something called the renin-angiotensin aldosterone system. But for right now, aldosterone, mineral corticoids, increases sodium and water absorption and raises blood pressure. That's what you need to know for this unit. But like I said, you're going to see this 3 more times. So other things coming from the adrenal cortex. So the gonatocorticoids are going to be weak androgens, male sex hormones, and insignificant amounts of estrogens. So androgens, though, are going to contribute to the onset of puberty actually in both sexes. We get the appearance of axillary and pubic hair. In adult women, this male hormone is, so they say, the contributor to libido or sex drive. And like I said, after a woman goes through menopause, her ovaries stop generating female sex hormones. That's where all the estrogen comes from post-menopause. So let's look at imbalances. So if there is too much cortisol, so hypercortisolism, it's also called Cushing's disease. And this is caused by chronic exposure to excessive glucocorticoid hormones, usually people taking corticosteroids for therapy. And so when they start to get these Cushing signs, that's when they kind of have to back off on those medications. It can also occur when the adrenal gland just produces too much hormone, so maybe a tumor or some other imbalance. Treatment, like I said, is usually going to be a removal of the cause, so back off on the drugs or remove that tumor. What it causes, the cortisol, it's a glucocorticoid, so we're going to get high blood glucose. So the clinical term for that is hyper is high, glyce refers to glucose, and emia means in the blood. To get this fuel, we are breaking down protein. So if this continues, there can be a loss of muscle mass. In bone, remember, it's calcium salts and collagen. If you lose that, you can get weakness and fractures. Also, it sort of causes this weird distribution of fat, and obesity can occur. But what happens, you get fatty deposits around the face and the upper back. So right here, it's called a buffalo hump. Then two, we have protein wasting in the muscles. So usually the arms and the legs are going to be very skinny and the weight gain is going to be in the midsection. So these are just classic Cushing signs. Two, once again, since cortisol, it has an anti-inflammatory effect. We're going to be suppressing the immune system. Someone's also going to have frequent infections. So those are all things you're going to see with hypercortisolism, Cushing's disease. So now let's go the other way. So now let's look at adrenal insufficiency or hyposecretion. So the term for that is Addison's disease. And this is going to develop when adrenal glands, basically, they fail. It can, you end up with a chronic shortage of those glucocorticoids and sometimes the mineralocorticoids, so sometimes aldosterone. So John F. Kennedy had Addison's disease. They kept it pretty quiet. This was before social media. And he was known for his good looks, and also he always had a tan. So one of the things of Addison's disease is what's called bronzing. And so bronzing, this is that tan that's all over. There's no tan lines to this. And that is because the adrenal cortex is not working. And so we have high levels of ACTH. You have to think, we got our chain of command. The captain's yelling at the anterior pituitary, the first mate. The first mate's going, okay, captain, I'm trying to get those the adrenal cortex going, so it releases high level of ACTH. The thing is, the pathways, ACTH, they're in the same precursor for this other metabolite, but basically it leads to an increase in melanocyte stimulating hormone. So the melanocytes get all excited, and so that's where you get the bronzing from. So that's a really just definite sign of that. Since cortisol is there to help recover from stress, this person is going to have difficulties with that. So we get low blood sugar. So hypo means low, glyce means sugar, emia in the blood. And we're also going to get low blood pressure. We have aldosterone being made by the adrenal cortex also, so we're not going to have that. So we're going to have hypotension. And so hypotension, that's the clinical term for low blood pressure. There's a whole lot of other symptoms that go with that. You can have weight loss, fatigue, weakness, abdominal pain, diarrhea. The treatment for that is replacement therapy. And so the difficulties, and with the difficulty, I'm sure, in the presidency, I'm sure he had a little stress there with the Cuban Missile Crisis and everything else, but to get the proper dosage of cortisol based on the amount of stress someone is experiencing. And so it's a little tricky with the replacement therapy for Addison's disease. So the adrenal cortex, what can happen when there's a female child in utero, so an embryo or fetus, so before the baby is born, if there's an increase in production of those androgens from the adrenal cortex, you get masculinization of the genitalia. So imagine back in the day, before they knew about this, someone handed you a baby that has this sort of genitalia. What's your call? You're not here, so I can't see your face. Sorry about that. And so you get this ambiguous genitalia. If the adrenal cortex generates higher levels of male androgens in adult, it could also be the cause of hirsutism, so that male pattern hair growth. All right, please do not go walking around if you see a woman with facial hair, go, hey, I'm an AP2, I know what's wrong with you, it's your adrenal cortex. Don't say that. There are other causes. Sometimes it's just idiopathic for no reason. It runs in families. It could be polycystic ovary disease, but just, don't think like, hey, I can help you. Let me tell you what's wrong with you. Never a good idea. All right, so let's go ahead and color. Go back to your sheet. Do outline your adrenal cortex, because the adrenal cortex and the adrenal medulla, while they both respond to stress, they are going to do two different things. So you need to know the difference between the two. So the adrenal medulla is that middle part, responsible for that short-term stress response, releases epinephrine, norepinephrine. The adrenal cortex is for long-term. The biggies, cortisol, aldosterone, and those androgens. And so we're just going to keep it kind of simple. Cortisol, high blood sugar, so hyperglycemia, depresses the immune system. Mineralocorticoids, aldosterone, has to do with electrolytes, so increase sodium, get rid of our potassium, increase water volume, and then increase blood pressure. If you have hypersecretion, it's called Cushing's syndrome. Hyposecretion is called Addison's disease. Androgens, so male sex hormones, purpose, libido, puberty, that androgenic hair, so axillary hair, genital hair. And then if there is an imbalance, it's called adrenogenital syndrome. And this occurs, that masculinization of genitalia, if it happens in utero, so an embryo or fetus. All right, so if a male has hypersecretion from the adrenal cortex of those androgens, it really isn't going to make a difference, because it's going to be way more testosterone and male hormones coming from the testes. So that's why we didn't mention that. Okay, go ahead and color the thymus. So this gland right here is a bilobed gland. It is right above the heart, so it's in the mediastinum. It has to do with immunity, so that specific branch of your immune system. And that's kind of all you need to know for this. You need to be able to identify where it is. And we will mention that at length when we study the immune system. I just think it makes more sense then, but you need to just identify that is the thymus. We're going to add this in the blood chapter, but go ahead and color the kidneys and attach the kidneys over here. The kidneys' main function is to filter blood and make urine, so it removes our metabolic waste, does some other things. It has a big role in blood pressure, but it also releases a hormone called erythropoietin. And so I'll cover that when we do blood, so you can just kind of connect it right now. And then this is the pancreas. We've mentioned it. It releases two antagonistic hormones, insulin, which lowers blood sugar, and glucagon, which raises blood sugar. And it controls, like I said, blood glucose levels. It's going to work with the liver, skeletal, muscle, and also adipose tissue. Go ahead and find your pancreas. So testes make testosterone and other male hormones. And then this is female, so these are the female ovaries, which are going to make estrogens and progesterone. And so I'll target that when we cover reproduction, which is going to be our very last unit, so unit 5. So you just need to be able to recognize where they are and what hormones they make. All right, our very last gland, the pineal gland.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the pineal gland. The pineal gland was given its name because it has a pinecone-like shape. Unlike most brain structures, the pineal gland is unpaired, meaning there is only one. It sits directly on the midline of the brain. The function most linked to the pineal gland is the secretion of a hormone called melatonin, which is best known for its role in regulating circadian rhythms. The pineal gland is made up of secretory cells called pinealocytes, which secrete melatonin throughout the 24-hour cycle. Secretion is highest in the middle of the night. It begins to decrease as it gets closer to dawn and is lowest during daylight hours. This schedule of melatonin secretion is regulated by signals from the retina about light in the environment, which travel to a nucleus in the hypothalamus called the suprachiasmatic nucleus, and then via an indirect route to the pineal gland. The main function of the suprachiasmatic nucleus is to control circadian rhythms, and in addition to sending information about ambient lighting to the pineal gland, the suprachiasmatic nucleus also uses levels of melatonin as a signal to provide information about the time of day. Because melatonin levels are highest during the hours of darkness, melatonin activity can be used as a signal that circadian rhythms should be in their nocturnal stage. If melatonin levels are high and someone is still wide awake, it is an indication circadian rhythms are not in sync. This might happen, for example, after flying across several time zones. In this case, melatonin is used by the suprachiasmatic nucleus as a signal to get circadian rhythm back on track. Due to its close association with nighttime and circadian rhythms, melatonin has also been investigated as playing a role in promoting sleep, but the true relationship between melatonin and sleep is still unclear.
Okay, so perhaps you've taken melatonin to make you drowsy. So there it is, located the roof of the third ventricle in the brain. I said it releases melatonin at night in circadian rhythms. It is a modified amino acid. I don't know if you remember that this was in the news that if you eat turkey that then you're going to be sleepy. That is actually not true. What they do know about the pineal gland and the release of melatonin, though, is that it is inhibited by blue light. So if you're having difficulty sleeping, the LEDs that come off of our screens actually inhibit the release of melatonin. So you might want to just back off on your screen time if you're having difficulty falling asleep. It also, they know it plays some sort of role in reproduction. They don't really have that worked out yet. They know that if melatonin is high, there can be a delay in the onset of puberty. Okay, so let's go ahead, our last one, go ahead and color in your pineal gland. I know it's super tiny, just make a little dot there and connect it to that label. Okay, so just reminders, since this is all new to us. So now that you've colored your structure function sheet and you've attached it to the right label, make sure your name is on it. You're going to upload it to the Detail Dropbox by the due date. There's going to be a link for you in your checklist. Make sure now that you've done the lecture for endocrine, go to lab. There are Quizlets for both the lab portion and the lecture portion. Make sure you play them, but don't get Quizlet dumb. And what I'm saying by that is, you know how like if you click through Quizlet enough and play it in that multiple choice way, you kind of like, oh yeah, that's the one with the big yellow arrow. So do read all the information on the card. Always, I just want you to know I'm here for you. Shoot me a message if you need help. Fastest way to get me is through Remind, and I'll just answer you very quickly. Hey, have an awesome day, and I'll be back for Next is Blood.